How's it going, guys? We have a past level question for cardio physiology step 1, as well as internal medicine 2 CK. This type of schematic, if you've been following my content, I've made YouTube clips on this before. It's also my cardio PDF. And this stuff is assessed on step 2, okay, even though it appears very step 1-esque. So we've got oxygen tensions at different chambers of the heart/vessels, and question wants to know what's going on here, okay? Now, the first thing I'm going to mention, because some of you get confused, and you always ask this, is why do we have a 99 and 96% step down from the pulmonary veins to the left atrium? NBME will do this. This isn't me being creative. This is because of the Thebesian veins, holy shit, which drain the myocardium itself. Okay, so deoxygenated blood can empty into all 4 chambers, but saliently the left atrium. So this is a normal physiologic drop down, nothing to do with the actual question here. So what's the diagnosis / what are we going to see in this patient? Slash the explanation for the findings. Choice A, decreased systemic vascular resistance. Wrong fucking answer. Just a nonsense answer choice that has no relation. I mean, if you had decreased vascular resistance, it's not going to affect the oxygenation in the heart. It could increase ejection fraction. For instance, if you have left heart failure and you give an ACE inhibitor or an angiotensin II receptor blocker, then you decrease afterload. That can increase ejection fraction. This can also be an answer for septic shock. Okay, that makes sense. Wrong fucking answer. Choice B, diminution of left ventricular ejection fraction. Wrong fucking answer. So let's throw in some fancy vocabulary word that just means to decrease. Okay, so students choose weird answers when they don't know what's going on. So if we have a reduction of left ventricular ejection fraction, it's not going to affect the oxygenation here. You can clearly see there's no difference in oxygen tension between the left ventricle and the aorta. This would be the answer for left heart failure, okay? If they told you, let's say, a patient gets shortness of breath when going up the stairs or walking around the street, okay, that's decompensation of the left heart with increased oxygen demand / exertion. Choice B, wrong fucking answer. Choice C, extracardiac left to right shunt. Wrong fucking answer. So, however, this will be correct on the NBME exam / USMLE for patent ductus arteriosus. So the PDA, the ductus arteriosus, is going to connect the descending aortic arch to the proximal pulmonary trunk. And after birth, it's going to be going left to right. And it's clearly outside the heart. So it's extracardiac. Now, NBME does this. They'll literally give you, let's say, congenital rubella syndrome, because that's what causes PDA oftentimes. And they'll ask you extra, intra, left to right, right to left. They'll have different combinations of what's going on. The answer is extracardiac left to right shunt. If that were the case here, we would have a step butt in oxygenation from the right ventricle to the pulmonary artery, which we clearly don't have. Choice C, wrong fucking answer. Choice D, increased pulmonary vascular resistance, correct answer. Patient's got Eisenmenger syndrome. We clearly have a step down in oxygenation between the left atrium to left ventricle, which is impossible unless we have a VSD where we have a right to left movement of deoxygenated blood from the right ventricle to the left ventricle. Now, I didn't give you any information about the patient's history. Okay, VSDs are not cyanotic at birth. They're left to right at birth. But over time, you're going to have increased blood flow from the left ventricle to the right ventricle. It's got to go through the pulmonary circulation. The pulmonary circulation doesn't like that increased blood flow. So over time, it'll constrict to compensate. Its musculature will increase. That's going to cause afterload back on the right ventricle. And eventually, you get a shift from left to right, back to right to left, Eisenmenger syndrome, okay? And they like increased pulmonary vascular resistance as the etiology for Eisenmenger syndrome. So they can give you Eisenmenger syndrome and they say, what causes it? And they'll have right ventricular hypertrophy listed. It's actually wrong if they list increased pulmonary vascular resistance alongside it. So you want to be careful. It's very buzzy. I said it's pass level, maybe medium difficulty, but we can eliminate to get there, not dramatic. So let's just hop to the finalized choice here. Intracardiac left to right shunt, wrong fucking answer. Okay, so I mean, just threw it in here with choice C, juxtaposed it to be a bit confusing, but as I just harped on, this could in theory be a VSD early on, and we would have increased oxygenation from the right atrium to the right ventricle if that were the case. Wrong fucking answer. You know the deal. Once you make more content, I feel like my stuff's growing channel. Appreciate your time. That's it.